I'll try and move along because I don't want my slides to go off. This was where we're supposed to go to a live case, and as I mentioned earlier today, we had the primary case actually came in, was getting stabilized and doing all the things we talked about until they suddenly, without any forewarning, ended up with a rupture, a probable rupture, and succumbed to that rupture this weekend. The secondary case we had apparently has just had a stroke also. So again, showing the complexity of these complex aneurysms extending up involving the subclavian artery. So what I thought would do is go in and have a discussion in a taped case that we have, always have a backup, of management of some of the new technologies using the P-branch graft. I'll spend some time discussing some of the data that we have available and then go over to the presentation of the taped case. Because of regulations within the FDA and everything else, I do want to say that this is a case that was not taped specifically for this, but was purely accumulation of the saved fluoro runs that were obtained during the natural procedure of the case, and not specifically a taping of the case for presentation. Study design, we looked at a prospective non-randomized study, and this is part of the IDE. We have a single center IDE, but we also have collaborated with other centers for this, and it's for use of juxtarenal aortic pathology. You can have 4 vessels being involved with 2 branches, 1 fenestration, and then 1 scallop. Aneurysms have to be greater than 5 centimeters or double the normal aortic diameter, or growth of greater than half a centimeter within 6 months, a PAU of greater than 10 millimeters in depth and 20 millimeters in diameter. They will have to commit to follow-up for 5 years. Here's the P-branch as compared to the Z-fin. Here you can see on the graph, this is the pivot technology, go into more detail. Here's the SMA fenestration and the scallop for the celiac. Different from what we do with a lot of the fenestrated grafts, P-branch is really based on the SMA. That becomes your ground zero, if you will, and all your planning is based on moving the SMA in a 3D reconstruction to the 12 o'clock position, and then see if these pivots will actually allow you to be placed for the management of the renals. You can have, in our IDE, you have to have 15 millimeters below the celiac and not involving the SMA to be included. So aneurysms involving the renal arteries themselves are not excluded, which by the IFU are excluded in Z-fin. Again, a closer view of it showing the P-branch graft. Then, like a turret on a tank, it gives a lot of flexibility, anterior, posterior, as well as superiorly and inferiorly for the location of the graft without kinking there. So this pivot technology is really what's made the difference of making this a more off-the-shelf technology compared to the fenestrated grafts, where fenestration simply means hole, and you have a graft there, and then the bridging stent has to be it's angled relative to this fixed point rather than the fenestration, the pivot here, which will move and give you a better seal zone. So this is early on in our study. We had 23 patients that had fenestrated grafts and 14 with P-branch. This is all part of the original IDE study that I had before Z-fin became FDA approved. Follow-up was just under 30 months. And basically what we saw is that with the P-branch graft, they were very similar to our Z-fins, but obviously we're able to get it within 2 days rather than waiting the 3 to 4 weeks as required for the fenestrated graft. Aortic size and configuration was similar between the two, except for a little bit more proximal extension of the aneurysm in the P-branch group. Fluoro time and procedural time was a slightly longer, again, because you have one more vessel involved in the P-branch technology, but not markedly different. And again, this was our initial procedure, the first 14. We've done probably close to 30 of the P-branches now, and there was a learning curve as we got started. Patients rarely go to the ICU now, except for comorbid conditions. Here's the thing, just for Z-fins, we had a combination of different type of components of that, basically small fenestrations, large fenestrations, and scallops. P-branch is a standardized configuration, 1 scallop, 1 fenestration, and 2 branches. If you look at the branch technology, we had 96% renal patency. We had one failure early on, mainly because of crush from the ancillary components for the distal component of the fenestrated graft, which we were able to rescue. And we had one kink right during Hurricane Sandy. We actually got transferred to us, but we were able to salvage after about 2 weeks. Clinical outcomes, again, we had no 30-day mortality. Late mortality was 4. None of them were aneurysm related. If you look at the Z-fins, again, we had 2 of the patients die long-term. One actually came in, was doing well until almost the end of the 5-year follow-up. He ended up with a pneumonia, which he had high fevers, which he did not seek medical therapy for about 5-7 days. And then on his follow-up CT scan at about 4.5 years, we found gas within the aneurysm sac, and he ended up with an infected aneurysm. We were able to go in and we explanted it, but he had a very protracted course and went to palliative care about 6 months after his explant. We had no ruptures and conversions except for the one for infection. And then the core lab imaging showed no graft migration nor loss of main bowel patency, no type 1 or type 3 endoleak. So I think it was a very effective therapy that may allow us to have off-the-shelf technology now for managing many of these patients with infrarenal, juxtarenal, and even suprarenal aneurysms. This is the secondary interventions that we've discussed. Most of them were late in the Z-fin groups, and the P branch, again, was the renal artery occlusion because of crush. So the main thing is to do, this is a tape live case, so we'll try and walk through the technology of how we actually implant it. Some of this early on I'll skip through because it's more just a discussion that we've already had of the actual design itself. And again, there's an A and B configuration. So with the A there, the renals are at the same level. The B configuration, they're offset, allowing for some differences in anatomy. And it was really based on earlier studies that said if you take the SMA as your point of reference and do a scattergram, you can find this is how the patients will fit for a good number of the cases. Again, showing the flexibility. The other thing that's of importance is that there is a through-and-through wire, which makes it easy to cannulate the fenestration. And here's the through-and-through wire coming out. It also allows compression of the graft if you're in these tight aortic anatomies to give you better ability to try and engage the orifice of the renal vessels. This is our case. A 74-year-old gentleman has a 5.9 centimeter aneurysm, coronary artery disease, renal dysfunction, and hyperlipidemia. Here's his, again, coming up the SMA. You can see the aneurysm here. There is some disease up here, but still the main aneurysm component really comes right up to the renals. Here you can see the right renal artery coming off with the aneurysm extending right up to it, and same for the left renal artery. So this is truly a juxtarenal aneurysm and one that was a good candidate for the off-the-shelf pivot graft. This is our 3D reconstruction of the aneurysm. Here's our initial angiogram, again showing the renal vessels here, celiac SMA. It is a little confusing. This is an earlier image of some of the earlier graphs we used, but it's like a little shotgun blast here with all the different markers. So when it's constrained, it's a little tougher, but you can come in and once you kind of mark it out, you have a horizontal and vertical marker, which is your point of orientation. You move your image intensifier so your SMA is at 12 o'clock. We put a localizing wire in the left renal artery, as you see here. The graft is deployed, and this is the earlier one, but the large fenestrations markers are for the main outbounds of the fenestration, and this is the actual area of the graft itself. Here you can see you come up through that through and through wire with your sheath, and you have the little curlicue catheter coming in here. Again, this shows the opening. This is the boundaries of the fenestration. And then using the curlicue, you can actually come in and work through the renal vessels and get out with a Rosen wire. You cannot advance your sheath because of the through and through wire, so you leave that part with a catheter out, and the one you can come up over the other fenestrated wire. Here we came out and we're able to go up, brought a wire up through the sheath that we brought up to the fenestration. curlicue catheter again, and you're able to flex that and move that in and out of the sheath to change your angulation until you're able to engage the renal vessel, as you see here. Then you come out with a flexible catheter to go out into the renal vessel itself, and then come with a supportive Rosen wire to give you stability as you come through. Again, we had, then you come out, here's the SMA. I've changed the technique, and I tend to catheterize the SMA first now, but this allows you to access into the SMA, come up with your wire, and go out through the single fenestration here for the SMA. And here we're just with a hydrophilic wire, floppy glide wire coming out. Once we have it going through, we'll then come up with a catheter wire and then a sheath over the Rosen wire here. So now we've had catheterization of SMA, putting our stent out to act as an obturator there. We then remove the through and through wire and then deploy the top cap. Sheaths and dilators go out into the renal vessels as shown here. Again, this is an off-the-shelf device, so it makes it a little much more convenient. Now we're coming in, before we deploy our stents, we're coating, using a coda balloon to kind of iron out the fabric of the graft around the aorta. And then we'll come in and we'll do selective stenting as we go through. Here's the fenestrated left renal fenestration. We'll flare that, come out and do the same thing. There's an angiogram showing good flow with good seal here at the left. Coming out to the right, you'll do the same thing, and then we put a stent in the SMA to help make sure that that stays appropriately oriented. By protocol, we use covered stents, but certainly you can use a bare metal stent if you have good orientation of your graft and aneurysm doesn't go that high. Here's the cannulation coming up for the secondary component. This is the bridge down to go to both legs. Once we are sure we are in that contralateral gate of the bifurcated graft coming down to the iliacs, we'll then come in and we'll do retrograde angiograms, very similar to the EVARs that we all have seen before. Here's, put a marker catheter in, see the origin of the hypogastric artery, and then we'll just bring a covered iliac stent down to the origin of the right hypogastric artery, and then balloon the interface between the two. Once you've done that, you'll deploy the ipsilateral limb coming down, and then you can build down further if you need to give you a good seal going to the hypogastric. Here's your completion angiogram showing good flow going to celiac SMA and the renals. This is another case, a 92-year-old woman had a complex aneurysm. Here you can see coming in the renals, the aneurysm here, then a very tortuous aneurysm. And this is coming again with another pivot graft coming in, showing again the versatility, dealing with these very complicated angulated anatomy and the good seal associated with that graft using the same technique as we outlined in the first part of the video. And there's the completion angiogram, again showing its ability to mold to that area. I'm a firm believer in trying to use our interventions to match the anatomy of the patient, not try and make the patient's anatomy conform to our endografts. I think this is again showing that, and the follow-up we've had in these patients have been excellent without major complications, and now going well over 5 years. So that's a brief kind of tour through the use of a new novel technology for the treatment of patients off the shelf. I think this is something that will allow us to have another treatment option for these patients that hopefully will not require the manufacturing time that can be a problem. Telling the patient they have to wait 3 to 4 weeks to wait for the graft to be made is a challenge, and certainly they always come in and say, well, how do you know my aneurysm is not going to rupture if I have to wait 3 to 4 weeks? And you're like, you don't, but the odds are that, you can wait this long and we'll get all your cardiac clearance and everything else done in the interim. But I think if we had a off-the-shelf alternative, I think certainly most of us would like to be able to treat these patients more expeditiously. So I'll stop there and see if the panel has any questions about P-branch or anything in general.